Next session, that is cardiac and diabetic conversations. In this we have got a cardiologist and also endocrinologist, Dr. M. Gopal Reddy and Dr. Ram Boddula.
Good afternoon, dear colleagues, respected teachers. This session is slightly different from the routine lecturing. Basically, what we wanted here was to address specific issues in our routine clinical practice. Here we would be presenting a couple of cases, and myself, endocrinologist Dr. Raman and nephrologist Dr. Kavita would be addressing specific issues. I'll go to the first case directly. The first case is a diabetic with no established coronary disease. He is a 48-year-old. Known diabetes past 5 years, blood pressure 120/80 within the goal, the ECG is normal. For routine health check has a echo TMT which were normal. Basically there's no evidence of any established coronary disease. He is obese, 80 kilos with a body mass of 30. He is on glimepiride metformin, a combination pill plus a pioglitazone. He is compliant with diet, exercise regularly, and is asymptomatic. His A1C is higher, uncontrolled diabetes. So basically, what does a cardiologist do? There is no role for interventionist here, but yes, there is a role for a cardiologist, a preventive cardiologist. Clinically, this patient is asymptomatic. So when what we understand from the 10 years risk study from the Framingham is the largest and the most renowned data. What they have shown is any diabetic patient stands a 10-year risk of CAD that is equal to patients already having a coronary but non-diabetic. And the second point they highlighted was the coronary disease is the primary cause of death in most diabetic patients. And also the diabetics, when they suffer an acute MI, they have a higher mortality. And following a coronary disease, they have very poor long-term outcomes. So what are strategies? So what does preventive cardiology do here? Basically, there are specific guidelines. These are from the ADA. The lipid should be less than 70 in highest, less than 100 in high risk. What do the highest and high risk mean here? The highest means diabetes plus one risk factor is high risk. Like the conventional risk factors are only 4, the hypertension, diabetes, smoker, the family history. If of these 4, if diabetes plus 1 is high risk, the goal should be less than 100. And the highest is 2 or more risk factors. A diabetic with a 2 or more risk factors are called the highest risk, and the LDL should be tried to be kept at less than 70. Similarly, in HDL should be more than 14 males, more than 15 females. Triglycerides, it is less than 130. The blood pressure as per the ADA is 130/80, but I heard the ESC has changed to 140/90. The aspirin, there's a definite role in secondary prevention. What I mean is a patient already has a established CAD, definitely aspirin should be given. But what as a primary prevention? What we see in routine practice is majority of the diabetic patients are on aspirin and sometimes on both aspirin and clopidogrel. Are we right in doing it? I will just highlight some of the data available. We have a lot of calculators in the web, in the smartphones, which give the risk factors based on the cardiac risk based on your risk factors of 4 risk factors. The hypertension, diabetes, male, smoker, and the family history. When you calculate these 2, it gives a risk. So if the risk is more than 1% per year, then probably yes, you are right in giving aspirin. Suppose the risk is less than 0.5%, should not be given aspirin. And when the risk is between 0.5 to 1%, yes, there's a clinical judgment involved. But why is this? It is because the aspirin itself has a 1 in 1,000 risk of GI bleed. So logically, when somebody has a less than 0.5% risk, that means a 5 in 1,000 would have a coronary. I would say 2 in 1,000 a risk for a low risk patient. And aspirin itself causes 1 in 1,000 bleeds. So basically, there's no reason for giving aspirin because it kills more patients by GI bleed than the coronary would affect. In fact, we have at least nowadays seeing 1 or 2 patients with a major GI bleed for unindicated aspirin use. I would request Raman to come and give his endocrinology perspective.
Good afternoon, respected teachers and my dear colleagues. So I will be discussing the glycemic aspect of this particular case. So as we have seen the patient profile, see this patient, middle-aged patient having diabetes of short duration, that is 5 years, and on 3 oral hypoglycemic drugs. So this case gives us an opportunity to screen for complications, because we know that type 2 diabetes can present with complications at the time of diagnosis itself. And all the guidelines also say that we should screen for the complications in a type 2 diabetic at the time of diagnosis. So consequently, in this patient also, we need to screen him for the complications. The data has been shown already. He doesn't look to have obvious cardiovascular complication, the macrovascular disease, but we should screen for microvascular complications, which include the retinopathy, nephropathy, and neuropathy. So the detailed fundus examination by an ophthalmologist is recommended. And for ruling of nephropathy, the urine albumin by creatinine ratio in a random sample or a microalbumin together with the complete urine examination to avoid false positive reactions in case of any associated urinary tract infection, which can give a false positive report. So, and detailed neurological examination is also required to check the touch, pain, and vibration sensation using the monofilament examination. And the jerks, the mainly ankle and knee jerks, can be examined to rule out document any neuropathy. And also the peripheral vascular system can be, the integrity of the peripheral vascular system can be documented by simply calculating the ankle brachial pressure index. So the prevention is an important aspect in this patient. And the other important aspect in this patient is prevention of complication, because he is relatively young patient having no comorbid conditions at present. So in view of his long life expectancy, we need to prevent the complication in this particular patient. So prevention is much more important. So towards this goal, we need to optimize the blood sugar, blood pressure, and lipid control. All three need to be achieved to prevent this patient to go into the complications. So the lipid and blood pressure has been discussed. So I'll focus on the optimization of blood sugar control in this particular patient. So if you see the drug profile, what he is receiving, he is receiving glimepiride 2 mg BD and metformin 500 mg BD together with pioglitazone 30 milligrams once a day. And his body mass index is on the higher side, 30 kilogram per meter square. So seeing this drug profile, is this patient receiving a right drug combination is the question. So if you see the guidelines, the last year published 2012 ADA ESD guidelines, the management of hyperglycemia in type 2 diabetes, a patient-centered approach. So they say that you should involve the patient in drug selection at each step. And what are the drugs, how to select the drug, also they have given the guidelines. So after the initiation of metformin at the onset of diabetes, subsequently the next second drug, when you select to add second drug, you need to consider 5 important aspects: the efficacy of the drug in terms of HbA1c reduction, hypoglycemic tendency, the drug should not cause hypoglycemia, and weight, it should be weight neutral or it should help to reduce the weight, and side effect profile, particularly GI side effects, and even cardiovascular safety is also important when you start a new drug. And of course the cost of the drug is also important. So these 5 important aspects have to be considered before selecting a new drug after metformin in any diabetic patient. That's what these ADA ESD guidelines mention. So you can select, you have multiple drug options available, but these are the guidelines we should remember. So seeing these guidelines, in view of his high body mass index, see pioglitazone, we know that it increases the body weight, and so consequently pioglitazone may not be a better option, although it is not contraindicated in this patient. And we know the recent controversy with pioglitazone, what happened, it has been banned recently by the central government, seeing the linkage between the reports linking the pioglitazone with the bladder cancer. But again, after extensive criticism which has erupted, the ban has been revoked recently, last week. But this time it has become available with a new product label warning, saying that pioglitazone should not be used as a first line drug in management of diabetes, and it should not be given to patient with history of bladder cancer or any patient with uninvestigated hematuria. It should not be given. And patient with other risk factors of bladder cancer, which include the occupational or chemotherapeutic drug exposure like cyclophosphamide, or the family history and increasing age. So these risk factors should be considered before initiation of pioglitazone. And also they say that after initiation of pioglitazone, for next 3 to 6 months, if the blood sugars not improve, you better withdraw the drug. So these are the newer guidelines which are recommended before using pioglitazone. So this drug in this particular patient profile, if you see, doesn't appear to be an ideal option in view of his increased BMI. So then what are the other options to optimize the blood sugar control in this patient? We have multiple options. We have many class of oral drugs available. So to mention a few, I'll discuss. We can do up titration of the metformin because he is receiving sub-maximal dose, 1 gram per day. So we can always increase it to 2 grams per day. And his blood sugar profile, the fasting is 120 and postprandial 270. So predominantly he is having postprandial hyperglycemia. So you can up titrate the sulfonylurea dose, particularly the morning dose, to address the predominant postprandial hyperglycemia in this particular patient. And in the process of intensification, probably you may require to add alpha glucosidase inhibitors also to bring down the postprandial blood sugars to reduce the HbA1c. Or the other option could be the up titration of metformin plus addition of other agent like gliptin or the GLP-1 receptor analog. The advantage being the GLP-1 receptor analog can cause weight loss in his obese patient. And gliptin is also weight neutral, we know that. So addition of gliptin or GLP-1 receptor analog while continuing the same combination of pill of glimepiride and metformin probably will help. And probably this patient may also require the addition of alpha glucosidase inhibitor because of his predominant postprandial hyperglycemic state. So you can use the drugs effectively and optimize the doses to bring down the blood sugars and to see that HbA1c comes down to the target level of less than 7%. And even the role of insulin also is there in this case. If you cannot achieve optimal glycemic control in spite of using the up titration of this metformin and sulfonylurea or addition of gliptin, you can always add the insulin also depending on the patient's blood sugar profile. In case if the postprandial blood sugar persistently remains high, you may add a prandial insulin. If the fasting is high, you can probably add a single dose of basal insulin. So there are multiple options basically. So my idea in discussing this patient is because of his weight, pioglitazone may be withdrawn and you can try to increase the other drugs, choose other drugs which are weight neutral or which helps to reduce the weight, and at the same time the cardiac safety is maintained. This ends the first case. If any discussion we can have and then move on to the second case.
Any questions regarding the case management, any doubts you have? One thing I want to ask, you said sulfonylurea up titrating already is overweight. Is it wise to up titrate sulfonylurea, which is again weight gain?
Yeah, it may contribute to weight gain definitely. So that's why we have multiple options. It's not the only option I mentioned. So depending on the patient's affordability, so if the patient is not able to afford the costlier drug like gliptin or GLP-1 receptor analog, so we are left with increasing sulfonylurea. So we have to judge depending on the patient's situation. So that's only one option. But addition of gliptin or GLP-1 receptor analog definitely is better, because it doesn't increase the weight, it may help to reduce the weight. So that's always superior, definitely. Yeah, glimepiride compared to gliclazide probably is less weight gaining compared to glimepiride. So replacing glimepiride with gliclazide also probably is a good option, definitely.
There are no other opinions, so we can carry on with the next.
It's actually cumbersome for us to shift but actually this was planned as a panel discussion. But this is the first time Dr. Srinivas Kumar wanted specifically in this pattern. So the next is a diabetic 62-year-old male, diabetic in his past 15 years, long-standing, blood pressure on the higher side 150/90, GFR is normal, ECG shows a left bundle branch block, the echo shows a EF of 35%, which is a severe LV dysfunction. He's in function class 2 heart failure. This angiogram was done, it shows an insignificant CAD. So again, BMI is 25, his compliant diet on glucoside 80, metformin 500 twice daily. The fasting post-lunch are reasonable, A1C is higher. What is the cardiologist perspective? When we see the combination of a left bundle branch block, a severe dysfunction, and normal coronaries in a heart failure patient, the diagnosis is quite obvious, it's diabetic cardiomyopathy. It is identified more than 25-30 years back and is defined as a distinct entity characterized by the presence of abnormal myocardial performance or structure in the absence of epicardial coronary disease, hypertension or significant valve disease. The pathophysiology is still not very clear. Initially, there were a couple of thoughts, like one school of thought was probably this patient would have sustained multiple attacks in the coronaries and they were recanalized. As a reason, we are not able to find the coronary disease. Then the second thought was probably they are genetically DCM dilated cardiomyopathy patient with a added diabetes. But these two school of thoughts are not now valid. Now what it is hypothesized, still not proven, is it's probably it's multifactorial, impaired calcium homeostasis, activation of the RAS system, there's increased oxidative stress, and the altered metabolic substrate, metabolism, like increase in free fatty acids, which can lead to deposition of the free fatty acids into the muscle cells or in between the muscle cells, can lead to weakening of the collagen tissue and ultimate dilatation. So basically it involves hypertrophy, myocardial fibrosis and collagen deposition that leads to increased basement membrane thickness. So after knowing this patient has a diabetic cardiomyopathy, what next? Because he doesn't have a coronary disease, the management is as per the guidelines for heart failure, like any routine dilated cardiomyopathy. The management should center on beta blockers, ACE inhibitors. If somebody is not tolerating ACE inhibitors, he should be put on a vasodilators combination of nitrates plus hydralazine, digoxin, diuretics as per the patient's symptom class. But I would like to stress here that because the pathophysiology involves a RAS system, the ACE inhibitors, ARBs probably are the best drugs, and a school of thought is probably because of the altered autoimmune system also. That's the reason beta blockers also should be mandatory. So ACE inhibitors, beta blockers are the center for the management of a diabetic cardiomyopathy. The rest, digoxin, diuretics, based on the symptom class, we can adjust. I would request Raman to take over for the metformin. In the last case, he would go directly.
Yeah, this second patient who is having a diabetic comorbid cardiac condition is receiving sulfonylurea and metformin combination again with suboptimal glycemic control with HbA1c at 8%. So I would like to focus on the usage of metformin in the presence of heart failure patients, because traditionally metformin has been considered as contraindicated in patients with heart failure. But recent studies reveal its effects beyond the glycemic control. It has been shown to cause improvement in endothelial dysfunction, hemostasis, reduced prothrombotic state, reduced oxidative stress, insulin resistance, of course, we know, and modification of the lipid profile, the reduction in the triglyceride levels. All these things have been documented. And it also has been shown to improve the myocardial function in animal studies via activation of a signaling mechanism by activation of AMP activated protein kinase in myocardium. This is documented in the animal studies basically. So these properties may contribute to decreased adverse cardiovascular outcomes otherwise not attributable to its anti-hyperglycemic effects. So we have some data on the metformin, the most recent, the last month's publication, published in Circulation Heart Failure Journal, which is an affiliated journal to the American Heart Association. The comparative safety and effectiveness of metformin in patients with diabetes mellitus and heart failure. So this is a systematic review of meta-analysis of observational data basically involving 34,000 patients. So they have done extensive search and identified 9 major studies which have used metformin in diabetics with heart failure and collated the data. So all these studies have shown that usage of metformin has been associated with reduced all-cause mortality used in patients with stable CHF if the renal function is normal, and it should be avoided in unstable or hospitalized patients with CHF. Even US FDA has also revised the list of contraindications for metformin in 2005 itself. They said it is no longer contraindicated in heart failure patients if the patient is stable, even though requiring pharmacological therapy for heart failure. But it should be definitely avoided in unstable patient who is having active CHF. It is contraindicated because it increases the risk of lactic acidosis. Again, this is 2013 recommendations of American Association of Clinical Endocrinologists. They have given the profiles of anti-diabetic medications as highlighted in the different colors. They have highlighted the safety of each class of drugs with regard to the renal, GI tract and cardiovascular system. So if you see the metformin, the CHF they mentioned is neutral, whereas in CVD patients it is beneficial. Similarly, the TZDs, it is moderate risk of increasing CHF, but in CVD it is neutral. In the newer class of drugs, bromocriptine, some safety data is there with regard to cardiovascular system. It's a newer drug, and SGLT2 inhibitors, which are yet to come into our market. The other drugs, they are having neutral effect in the cardiovascular system. So metformin is definitely neutral with regard to heart failure. So you can definitely use it safely in heart failure patients. So coming to the present case, this patient is having fasting 140 and postprandial 210 and HbA1c of 8%. So given his cardiac comorbid condition, I would not aim to reduce the HbA1c to less than 7, but an appropriate goal appears to be, in this case, 7 to 7.5% of HbA1c appears to be an appropriate goal. So to achieve this mild reduction in the HbA1c, so seeing the evidence that metformin can be safely used in heart failure, I would not like to withdraw metformin in this patient. I would continue the same combination pill of gliclazide and metformin, but to further reduce the blood sugars and optimize the blood sugar control, we can simply add a newer drug, that is gliptin or GLP-1 analog, because it is the weight neutral and cardiac friendly drug. So by adding a single dose of a gliptin or a GLP-1 analog, we can reduce both fasting and postprandial blood sugars little down, and consequently HbA1c can come down close to 7 or 7.5, which is an ideal glycemic target for this patient.
The question essentially is the cardiac safety of the anti-diabetic drugs.
Yes.
Is there any difference between different sulfonylureas, like glibenclamide after glyclazide?
The cardiac safety of sulfonylurea, it is the evidence is inconclusive basically. The first report, the suspicion came from UGDP data in 1970s. The tolbutamide usage has been shown to increase the cardiovascular mortality. Since that time, they are being suspected as having increased cardiovascular morbidity and mortality. If you see the distribution of the receptor, basically sulfonylureas, they bind to SUR1 receptor present in the beta cells, but they also have receptors in the vascular endothelium and myocardium also, but they are different receptors. SUR2A present in myocardium, SUR2B present in vascular endothelium. So sulfonylureas bind to all the receptors. So glibenclamide, out of these all the existing sulfonylurea drugs, glibenclamide has been shown to have equal binding affinity to SUR1 in pancreatic the receptors and the myocardial receptors. So by that equal affinity, it has been shown to cause the adverse effects, particularly the ischemic preconditioning, which is the natural defense mechanism in the myocardium in response to ischemia. This is vasodilatation. So this inhibits the ischemic preconditioning because it binds to both SOR1 and SOR2A receptors. It has been shown that glibenclamide is definitely abolishing ischemic preconditioning, but whereas other sulfonylureas, there is no conclusive proof. Even glimepiride also has equal affinity for SOR1 and SOR2A receptors, but there is no evidence that glimepiride is abolishing ischemic preconditioning. And gliclazide probably doesn't bind to the SOR2A. The affinity is very less. It mainly, the major affinity for the gliclazide is for pancreatic SOR1 receptors only. So apart from glibenclamide, the other sulfonylureas, there is no conclusive evidence to say that they are causing the harmful effect on the myocardium.
Any questions from the audience?
Why do you want to complicate the picture? See, it doesn't have a predominant postprandial hyperglycemia. Just by simply adding a gliptin, you can control both fasting and postprandial. Gliptin can reduce both fasting and postprandial. So, by addition of a single drug, you are able to achieve reduction in both fasting and postprandial. And he requires basically a small reduction because we are aiming to reduce HbA1c to 7.5 or 7.3 in this case. So if you reduce the fasting by 20 and postprandial by 30 milligram, probably we can achieve that target. So that can be achieved by adding a single dose. So if you can use that also, AGI can be added with each meal to reduce the postprandial, but it's not required. So you can always choose a simple addition to achieve the target. Yeah, definitely. See, but it all depends on the patient's blood sugar profile. If the blood sugar definitely, after giving the sulfonylurea and metformin, the postprandial peaks are definitely high, then you can choose that. But there is a chance, as you said, alpha glucosidase inhibitor can be given to this patient also, which will help to reduce the postprandial peak, and that will reduce the HbA1c. There is an option, definitely. But I was trying to discuss a simple measure. Just by adding a single drug, you can reduce both and you can achieve HbA1c reduction by a single measure. Gliptin's safety cardiac, till now there is no data to say that they are increasing the adverse harmful effects on the cardiovascular system. So with regard to the safety to the cardiovascular system, all gliptins appear to be equal. There is no superiority which is demonstrated with one gliptin over the other. Yeah, alpha glucoside inhibitors has definitely that safety data. So, but definitely, but you have to see the patient blood sugar profile also. The patient blood sugar profile predominantly having postprandial hyperglycemia, you can definitely choose. So I think both things will stand in this case. I am not saying that only gliptin should be given in this case. Alpha glucosidase inhibitor also has a role, but seeing the patient's blood sugar profile, so instead of giving 3 times alpha glucosidase inhibitor, if you give a single dose of gliptin, probably you will be able to achieve. If you cannot do that, then you can definitely opt for adding AGI. Yeah, but insulin, there is no data to say that using insulin will reduce improve the cardiac condition. So actually the suspicion is that the insulin also is implicated in the cardiovascular morbidity, although we do not have conclusive evidence. But there is no data to say that it improves the cardiac status. Yeah. Yeah, this the screening for nephropathy, the screening test, which is either protein by creatinine ratio or urine microalbumin, ideally it should be performed when once you achieve the good glycemic control, because high blood sugars, infection, CHF, uncontrolled hypertension, all these factors are known to influence. They can give false positive reaction result. So ideally, you are supposed to do it when the blood sugars are under control. Yeah, after controlling the blood sugar, then you screen for the nephropathy to avoid false positive the result.
Thank you, Raman. Thank you for the
There's one more case.
One more case.
There are 3 cases actually.
Since there is some information that lunch is going down, please be brief about the next case.
Okay.
Within 15 minutes, they are going to close. So be brief, the next case.
Yeah. So this is a diabetic with CAD and CKD, 66-year-old lady having diabetes for the last 10 years, blood pressure uncontrolled 160 by 96. The MDRD calculated GFR is 30 ml per minute with creatine 2.5 milligram per deciliter. The ECG is showing old inferior wall MI and echo is showing mild LV dysfunction. He has CAD status post PTC, underwent angioplasty before, but presently asymptomatic from cardiac point of view. And the antihypertensive drug telmisartan plus hydrochlorothiazide. This is the drug profile. And antidiabetic medications, glibenclamide 5 mg BD and metformin 500 mg BD twice daily. So she has poor appetite, gives history of hypoglycemic episodes, and the present blood sugar profile is fasting 130, post lunch 185, HbA1c is 7.4%, LDL cholesterol is 125 milligram per deciliter, and she doesn't monitor blood sugars at home. So this is the patient profile. So keeping in view of his the CAD and advanced CKD, what is the ideal drug again in this case? So she is on long-acting sulfonylurea, the glibenclamide, and gives history of hypoglycemic episodes also. So obviously in this case, long-acting sulfonylurea is not an ideal drug. And metformin again, traditionally it is contraindicated if the creatinine is more than 1.5 in men and more than 1.4 in women. And the guidelines also say that we should restrict the use of metformin between the GFR, estimated GFR 60 to 30. And once GFR is falling below 30, it is absolutely contraindicated. So her GFR has been mentioned as 30 ml per minute. So this makes the use of metformin unlikely in this patient. So both glibenclamide and metformin need to be stopped, seeing the profile. And I think insulin appears to be a better drug of choice in this patient. So although the patient is not willing for insulin, we can still try with other oral drugs which are safe in renal failure. Like we can use short-acting sulfonylureas, and probably gliptin in modified dose can be tried. But again, the first drug of choice should be in this case is insulin. And we can do that by starting a short-acting insulin or rapid-acting analog before each meal. Titrate, educate the patient to do self-monitoring of blood sugar at home with glucometer, and titrate the dose of the insulin dose to bring down the sugars. And in case if the patient requires the addition of NPH or long-acting analog to reduce the fasting is also possible. So basically, insulin is probably appears to be in this case a better drug because she is already at the goal. 7.4 is an optimal goal for her. We don't want to reduce it further, but the drugs are wrong drugs. So we need to replace the drugs and give an ideal drug which is safe in this case. So insulin I think is better. Although we have few other options like short-acting sulfonylurea and gliptins in modified dose, we can still try, but more than that, the insulin is better, I feel. So I'll leave the next part to my nephrology colleague to discuss the aspect on the hypertension and lipid management in this case.
Good evening, everyone. So I just want to add on to this so briefly about management of hyperglycemia in CKD patients. So as we said before, intensive treatment of hyperglycemia prevents albuminuria and also delays its progression. But as we heard before, we always have to be careful about the risk of hypoglycemia in these patients is very high because obviously reduced insulin clearance and reduced renal gluconeogenesis. So back. Sorry about this. So just as we know, we had a lot of studies in the past from 2000 and all, mainly the DCCT and the epidemiology of diabetes intervention studies are showing that confirming this reduction of the HbA1c27 delays the progression of the microvascular complications of diabetes, including the diabetic kidney disease. And intensive glycemic control with HbA1c of up to 6.5 is appropriate in young patients with a reduced risk of hypoglycemia, and also who are regularly monitoring the glucose at home, and also are in the early stages of renal disease and CKD 1 and 2. Whereas in CKD 4 and 5 is probably high risk to aim for this low levels of HbA1c because of increased risk of hypoglycemia. So this study has shown basically reduction to 6.5, reduction of reduced nephropathy by 21%, and reduce the need for dialysis and reduce the risk of death. And there's no evidence that intensive glycemic control slows the progression to the clinical endpoint of needing dialysis. But the more of evidence is about regression of the proteinuria, and we discussed about hypoglycemia and about dyslipidemia management. Just want to mention a few trials. There was SHARP trial. This is the largest study conducted mainly in the Europe and mainly in the UK population, where about nearly 9,500 patients were looked into with more than 40 years of age with a CKD of the stage 4 with the GFRs with the mean GFR of 27. And there's a treatment arm included statin 20 milligrams with ezetimibe 10 milligrams and a placebo. And these patients were followed up to 5 years. And out of these, in these patients, 33% of the patients were on dialysis and 23% were diabetics. So statin plus ezetimibe therapy was associated with significant reduction, 17% risk reduction of the primary outcome of major atherosclerotic events like coronary deaths, myocardial infarction, non-hemorrhagic strokes, or any revascularization procedure like peripheral vascular disease. And there's no reduction in the risk of all-cause mortality. And statin therapy, again, as said before, it doesn't improve your kidney functions or doesn't delay your progression of your kidney disease. So mainly is anti-atherosclerotic effects. So just a brief word about statins in dialysis patients. We know we have the 4D studies, a German study where statin was given to type 2 diabetics on dialysis. With increased risk of hemorrhagic stroke by 2-fold. And again, it doesn't show any reduction in mortality or any cardiovascular events. And this study, was again recently the Aurora study done where they included a large number of patients. The 4D study was criticized because they thought it was less number of patients in the study and only limited to the German. But this Aurora study is again a multinational study, included nearly 3,000 patients on dialysis, and this time is a comparison of rosuvastatin to placebo. And in this study, 26% were diabetic. Again, it showed there's no significant effect of the statin therapy on the primary cardiovascular outcome that included cardiac death or MI or stroke. And this is in dialysis patients. So again, the post-hoc analysis of this study showed in diabetics, it probably reduced, but also by the increased risk of hemorrhagic stroke by 5-fold. So general advice is that statin is not recommended in dialysis patients, but if the patient is on it, maybe you can continue, but do not start statins in dialysis patients. So for CKD population, yes, statins are beneficial from any stages, but in stage 4 and 5, you need to be cautious about the dose. The doses should be started slow and be carefully monitored for adverse effects like myopathy and hepatitis and all, because the risk of side effects are very high in these patients in CKD stages 4 and 5. So Albuminuria, again, as you all know, RAS inhibition is well-proven agent to block the development of albuminuria and slowing the diabetic nephropathy. And ACE and ARB should be initiated in any patient with diabetes and albuminuria with proteinuria levels in the microalbuminuria levels up to 30 milligrams per gram. And again, it's just a word about the combination drugs. ACE and ARB should not be used together as a dual blockade because there's risk of increased side effects like hyperkalemia and worsening renal functions. Again, ACE or ARB should not be started in patients with the CKDs 4 and 5 because there are some studies, especially in the UK, we have seen that there's increased risk of worsening renal functions when started in the CKD 4 and 5. When they're already on it, that's fine, you can continue as long as it's monitored, but do not start patients on ACE or ARBs for CKD 4 and 5. And again, this new drug, as you know, the direct renin inhibitor, aliskiren, again, the recent FDA guidance is that do not use combination drugs, ACE, ARB, or aliskiren, because of the risk of progression of the renal failure.